In the last two videos, we covered the functions of the respiratory system, and then I separated out um, the anatomic parts of the upper divisions of the respiratory system, just because it started to get a little lengthy. So now what we're going to do is we're going to shift our focus to the lower respiratory system and finish talking about the conducting airways, and then start getting a little bit into the physiologic anatomy, i.e. the alveolar air sacs, and talk about the basically the respiratory zones, or the areas where gas exchange occurs. And remember, just to review, that the structures of the upper divisions of the respiratory system are found basically are basically the nose, the pharynx, and then the larynx, and then the lower divisions are the trachea, and then not shown here in this picture are the bronchi and the lungs. Now, um, so obviously the logical next step then would be to talk about the trachea. The trachea essentially, and before we get into the trachea, let's just review that pretty much while we've been going over the anatomic structures, we've been essentially talking about the conducting airways. And remember, the conducting airways consist of the nose, pharynx, larynx, trachea, and the bronchial tree. All right, excuse me, and remember, the conducting airways, their job is to move air. All right, and while they're moving air, they're also filtering it, they're humidifying it, and they are also warming it. And the nose does most of that, and then the rest of the airways just kind of add a little bit more to it. So I just want to throw that little bit in there as well. So now the trachea, as mentioned, is the beginning of the lower respiratory tract. And remember, anatomically on the larynx, the area where the trachea begins is called the cricoid cartilage. So the cricoid cartilage is the border between the upper and lower division. All right, and then extending downward from the cricoid cartilage down to about 5 inches down to about the level of T5. All right, from basically the cricoid cartilage of the larynx to the fifth thoracic vertebrae would be the trachea. So, like I said, the trachea is about 5 inches in length. All right, which is about 12 centimeters, and about 1 inch in diameter, which is approximately 2.5 centimeters. All right. Now, one of the key structural components of the trachea is that it is constantly held open by incomplete rings of cartilage. So when we say incomplete, I mean a complete ring would look like this. Basically it's a complete circle. All right. Whereas an incomplete ring, the on the trachea, they look like this. All right. So on the posterior side, the ring is incomplete. All right. So this would be the anterior side. All right, and I'll come back to that in a second. And one thing to remember about the trachea is that it is anterior to the esophagus. All right, it's in front of that. And again, we're going to revisit that concept in a minute here. So if we look at the images of this, so basically here we've got the epiglottis. All right, this would be your thyroid cartilage. All right, and then basically down here. Basically down here, that would be the cricoid cartilage. All right, which would be the beginning of the trachea, and then traveling downward, descending from basically the larynx in the throat down into the mediastinum of the chest would be it would be the trachea. All right, and then there's about this depends on what book you read or which anatomist you talk to, but give or take, there's about 15 to 20 of those incomplete rings of cartilage that are holding the trachea open. And then there's basically soft connective tissue in between these incomplete rings that are adhering them together. So basically, the rigidity of the hyaline cartilage that's holding the trachea open at all times allows the trachea to stay open at all times. And then but the trachea is also very soft and it's very easy to deviate or move around. All right. And then basically, once we get down into the mediastinum, remember again at about the level of T5, there is going to be an area at the distal end of the trachea called the carnea. Okay, it's basically this kind of semi-triangular underwear-looking shaped piece of cartilage here, And the carnea is basically where the trachea bifurcates or splits in half to form the primary or the main stem bronchi. So basically, these main stem bronchi are extending into each lung. All right. So basically, air travels down the trachea, and then it is dispersed through these primary or main stem bronchi into each lung. So this would be the left main stem bronchus, and then this would be the right main stem bronchus. All right. Um, Now let's kind of revisit the idea of the incomplete rings of cartilage on the trachea, and then the relationship of the trachea to the esophagus. Now remember that the trachea is anterior. Okay, so if we look at the tubular structures of the throat, the trachea would be the most anterior tubular structure, and then you'd have the esophagus, and then the vertebral column. This would be the most posterior part because in the hollow center of the vertebral column, or basically of the spine, we've got the spinal cord traveling up and down. All right. Now, like I said, that's really key to remember because, like I said, when it comes to, remember in the last video I talked a little bit about intubating and placing tubes down people to help them breathe. But let's talk about this from a perspective of swallowing. Okay. So remember those incomplete rings of cartilage, they form kind of a horseshoe-esque shape. And basically, there's kind of a muscular fibrous membrane on the posterior aspect. So basically, kind of connecting the two ends of the fibrous membrane is a muscle called the trachealis muscle. Okay, and when this muscle contracts, it pulls the rings together a little more tightly and creates a little more resistance to airflow and allows us to basically kind of work harder to drive more airflow into and out of the conducting airways. All right, but the other important reason why the posterior side of these rings why they need to be incomplete is because of the esophagus right behind it. Now, we obviously want the trachea held open at all times because we want constant airflow into and out of the respiratory system. Because the diameter of the trachea is it's about 1 inch, and I mean in terms of your throat, that's pretty big. All right. Now because this is constantly held open all the time, the esophagus is basically partially collapsed unless we're swallowing food or drink, food or water. So basically, as we swallow food and that food travels down the esophagus is going to expand. Okay, the esophagus is going to expand. All right. And as the esophagus expands, it's obviously going to it's going to expand up against the vertebral column. But is the vertebral column really going to move? No. I mean, we're talking about solid vertebrae. We're talking about strong bones that are very strongly, say strong a lot, that are basically reinforced by lots of ligaments and connective tissue. The vertebral column doesn't have a whole lot of give to it, especially when the esophagus is pushing up against it. So in order for that bolus of food to travel down the esophagus, it's primarily going to expand outward into the trachea. All right. So basically, by having those soft rings, those incomplete rings, and that soft tissue on the posterior side of the esophagus, or I'm sorry, the trachea, that allows the esophagus to basically expand and allow for food to easily travel down towards our stomach. All right. Now let's think of this in terms of choking. All right, because when somebody chokes, it's not because they swallowed an object. Like when a little kid swallows a marble or puts something big in their mouth and they swallow it, or you're eating and you bite off more than you can chew and continue with the process and swallow the piece of food. Um, and basically when you swallow that large object, it doesn't go down the trachea because remember, when you swallow, the epiglottis is going to essentially cover the glottis and prevent that large object from going down. So it's only going to have one way to go, down the esophagus, and so what's going to happen then is the esophagus is going to expand outward, and then it's going to compress the trachea so much that airflow is going to be minimized or cut off. All right, so then basically that's how somebody chokes. All right, when a large object goes down their esophagus and then compresses the trachea, and then I mean, think about that. When you see a person choking, they're not really coughing. They just sit there. You know, the universal sign for choking. You put your hands on your throat, and a person's lips and nail beds start turning cyanotic or blue because they're becoming hypoxic. They're oxygen deprived. All right, and the reason why you see that the lips and nail beds because they're pinkish in color because of all the superficial blood vessels or capillary beds in that area. Now, when a person's choking, they're not sitting there coughing. They're trying to gag up the food, but they're not coughing. And remember, we've talked about this before that when you inhale actual big objects, whether it's a big drop of water or like a crumb or a piece of food, and it contacts the mucosal lining, the pseudostratified columnar epithelial tissue lining of the trachea, that mucosal membrane, there's lots of irritant receptors in there, and we cough and hack like crazy. All right, so and also think about the Heimlich maneuver. You get behind somebody, you take you take your thumb, you make a fist, you take your thumb, and then you ram it into basically right under the person's diaphragm, where the xiphoid process is. Basically, you're ramming the stomach. So basically, what you're doing is my cat just barked and she's eating it. That's awesome. Yay. Speaking of choking and things going up and down the esophagus, that was pretty. Sorry, folks. But basically, cat might distract me. Oh, Heimlich maneuver. So basically, when you're doing the Heimlich maneuver and you're doing those compressions against the stomach, what you're doing is you're compressing the stomach and forcing air up to try to dislodge that object so you can cough it up. Or that's why if there's no one around to help you with that, you press yourself up against a chair and thrust yourself against it, and you're doing the same thing. All right. So that's essentially how choking works. However, there are times when objects do go down the trachea, and that's what we call aspiration. Aspiration. So if a person aspiration or aspirates, if a person aspirates, what happens there is, like I said, some kind of object goes down the trachea. That usually happens when somebody's unconscious, or like for example, like when you hear about like a high school or college kid, they're partying too hard, they pass out, and then they vomit, and then that vomit essentially goes down travels down their trachea, and then basically it plugs up their bronchi and they can't breathe. Now that's essentially aspiration, and then basically what you have to do in a situation like that, or if a patient starts coughing up blood, they're unconscious or sleeping, they start coughing up blood, and that blood goes down there, like if they have an ulcer or they have some kind of trauma, and blood starts traveling down the trachea, they've aspirated as well. And then what you're going to have to do in a situation like that, clinically, is you're going to have to basically vacuum the material out and keep the airways clean, or to try to clean the airways out. And that's how, like I said, people die when they party too hard and they pass out and vomit. All right. So that's the difference between choking and aspiration. Choking is when a large object gets lodged in the esophagus and compresses the trachea, and then aspiration is when a person aspirates. That's when objects actually go down the trachea and obstruct airflow and suffocate the person. All right. But that essentially is the trachea, and then basically at the distal end of the trachea, we then form the bronchial tree. All right, and basically the bronchi then, are the dispersal systems into the lungs. Because remember, I said that one of the key functional aspects of the respiratory system is its large surface area, and that allows us to really maximize our ability to undergo gas exchange. And we'll take a look at a picture of this in a second. But the main parts of the bronchial tree, so basically at the carnea, or the distal end of the trachea, we form the primary or main stem bronchi, and then they branch into what are called secondary bronchi, and they're also called lobar because there's basically one that goes to each lobe. So the right lung has 3 lobar bronchi, and then the left lung essentially has 2. And then we've got tertiary bronchi, which basically start to disperse more out towards the periphery of the lungs, and then will eventually form bronchioles and then terminal bronchioles. Bronchioles are kind of the respiratory system's equivalent to arterioles. And I'll talk about that later on because the bronchioles play a key role in in airway resistance and constricting and dilating. They can play they just play a large role in airway resistance. All right. And one of the things you're going to see or notice about the bronchial tree is that as it disperses or travels further throughout the lungs, basically what you're going to start to notice is that there's less and less cartilage and more smooth muscle. All right. Because basically, just like the trachea, there's cartilage that constantly holds it open at all times. And then what's going to happen is the cartilage just starts to become less and less prevalent, and then there's more smooth muscle to constrict and dilate and control airflow. All right. So basically, what we have here, then, this is a pretty good picture that shows you these. Basically, the kind of the bronchial tree. And one thing you'll notice, just like the cardiovascular system, that as the bronchial tree disperses further into the lungs, the bronchi get smaller and smaller and smaller in size. All right, and eventually they're going to get so small that that the very ends of the tree, essentially, like the leaves of the tree, are going to be microscopic. All right, and then remember that there's a main stem bronchus. There's one that goes to each lung. All right, and these are the largest of the bronchial tree. Now, there's a slight difference between the right and the left main stem bronchi, and those differences is the right main stem bronchus. It's shorter. So let me write these down. So the right main stem bronchus, it's shorter. Okay, it's more vertical, and it has a slightly larger diameter. So it's just a bigger, slightly larger tube. Okay, and you'll also notice that the right lung essentially has 1, 2, 3 lobes. All right, it's got an upper, a middle, and a lower lobe, whereas the left lung only has an upper and a lower lobe. Now, remember in a previous video I mentioned that the liver is predominantly on the underside of the diaphragm, on the right side of the abdomen. All right, and basically that liver, especially during embryonic development, it puts so much. Basically that liver, the large size of that liver, basically influenced the shape of that. Basically of the right lung, which made it develop, which forces it to develop into 3 lobes, and also forces that right main stem bronchus to be shorter, to be a little more compressed, a little more vertical, and also shorter with a bigger diameter. So now the reason to know that is if somebody does aspirate it, if an object actually does go down somebody's airway, more often than not, it's going to go into the it's going to go into the right main stem bronchus and obstruct airflow into there, and then eventually, if someone continues to stay, like for example, someone's passed out and vomiting, that material will just continue to build up and then basically block airflow on both sides. That's why they say a lot of times if somebody passes out and pukes and they vomit, they say to roll them on their left side, because when you roll them over, it'll make it easier for that material, because like I said, the chances are the object is in the right main stem bronchus, or most of it is, and it'll be easier to get it out. All right, but that's essentially what's going on there. So then you see the main stem bronchi, and then you see the secondary bronchi going to basically each lobe of the lungs. All right, and then you see these tertiary bronchi just start to branch out and get smaller in size, and then eventually, once you start getting out to the peripheral aspects of the lungs, that's when you're going to start to see the microscopic bronchioles and terminal bronchioles. All right, and basically, once we start getting out to these tertiary bronchi, what you're going to start to see is instead of rings of cartilage holding them open, what you're going to start to see is plates of cartilage that are surrounding these bronchi. All right, and eventually, like I said, it's going to get to the point to where there aren't any left. So, like I said, you can essentially see here. So, picture this as being a lung. So, picture that as being a lung here. All right. So basically, like I said, this bronchial tree gets smaller and smaller as it disperses outward. All right, and then at the very end of, so basically we've got bronchioles that don't have any. This picture's a little tough because basically what you can see here, these are essentially the bronchioles, and then at the very ends of these bronchioles are the basically the terminal bronchioles. And at the very ends here, this is essentially where you find the alveolar air sacs that we're moving air into. All right, and so that's something to keep in mind. So basically, the bronchioles are loaded with smooth muscle. So kind of within the walls of the bronchioles, there are basically these really thick circular walls of smooth muscle that constrict and dilate that, like I said, regulate airflow into and out. And you know this, if we constrict the bronchioles, then that will lessen the amount of air going in, and if we dilate them, that will essentially increase airflow. Now, we'll talk about that more in another video. All right. But that essentially is the. Oh, and another thing I guess I'll mention here right now and come back to is that, for example, you know what? I'll just leave it be for now. So I'll talk about that later on. So that essentially is the bronchial tree, and then let's talk about the lungs and then the alveoli. The lungs are very soft, cone-shaped organs. They're soft. They're basically just lots of connective tissue and very simple epithelial tissue, lots of simple squamous epithelial tissue, lots of capillaries, some tissue fluid. There's not a lot to them. All right, and in the middle of each lung would be the mediastinum. All right, remember the mediastinum is a space or a cavity that basically is within the thoracic cage. It's a cavity within a cavity. And what was I going to say about? Now, the interesting thing about this is that each lung is enclosed by a pleural membrane. All right, a connective tissue outer membrane. So basically, this outer membrane, there's two parts of this. There's the visceral pleura and the parietal pleura. If you were to open up, whether you open up a fetal pig, you dissect a cat, you look at a human cadaver, if you were to open up the thorax, open up the chest, what you would see, basically what you would see is this kind of shiny whitish connective tissue that's on the wall of the thorax. It's basically on the rib cage, and you would see a very thin kind of film on surrounding each individual lung. Those are the pleural membranes, all right? And the membrane that surrounds the individual lungs is called the visceral pleura, viscera, organ, and the parietal pleura surrounding outside of is the pleural membrane that is around the thoracic cage. All right, and then in between is what's called the pleural cavity. All right, now basically this is kind of a potential cavity because under normal conditions, the lungs and the wall of the lungs and the thoracic cage are normally kind of stuck together. All right, there's a thin. I mean, like if you just took a paintbrush and just did one thin stroke over the lungs, that's about how thin the fluid is. There's a thin layer, a film of serous fluid. Remember, the word serous means watery. That essentially that basically helps lubricate the lungs. All right, because remember, the lungs are in contact with the wall of the thorax. So as we inhale and exhale, as the lungs expand and recoil, all right, they are rubbing up against the thorax, and as a result, that would create friction if that fluid wasn't there. Wherever there's friction, there's wear and tear. All right. Another thing that the pleural membrane does is it basically keeps a balance in the amount of air pressure in the thorax. All right. The pleural membrane basically, because under normal conditions, the pressure, if we're not breathing, if we're just sitting there not taking a breath, the air pressure inside of our lungs is equal to atmospheric pressure outside of the body. And then when we create the mechanical changes of our, during breathing, inspiration, expiration, that drives airflow. All right. So basically, this pleural membrane allows us to keep a balance of air pressure to prevent too much air from coming in. So think of this as creating a seal. All right, think of this as creating a seal. Now you'll see this, especially if you have ambitions to work in the emergency room or whatnot. You'll see this, when you have a victim get in a bad car accident and the rib breaks and tears one of these membranes. Or if someone gets shot or stabbed in the chest, or someone's hiking. I've seen this before, where someone's hiking, they fall down a hill and a stick goes through their chest. What's going to happen then is when you tear that seal, that's going to cause air to rush into the chest, and that's going to cause basically the where. So if this was on the left side of the thorax, air would rush in, surround that, basically build up on that pleural cavity, and build up pressure around that lung and cause it to collapse. All right. Now, the nice thing about the presence of these pleural membranes is that even though there's a hollow space in between the lungs, the mediastinum, each side of the thoracic cage, each lung basically is individual. All right. So basically, if air pressure were to build up around the left lung and cause that lung to collapse, the right lung still has all of its seals intact, and it's still going to remain that that right lung is going to remain basically not collapsed. All right. And when a lung collapses, that's what we call atelectasis. All right. So that's kind of something to keep in mind about that. And then basically the lungs extend from the diaphragm to just a hair above the clavicles. The apex of the lungs kind of goes just a hair, is just superior to the clavicles. So basically we would have one, so we'd have a right clavicle here, your left clavicle there. The apex just goes just a hair above. All right. And like I said, remember that the right lung, all right, that the right lung has 3 lobes to it. So basically, you've got the apex here, and then on the underside of each lung, we've got the base. All right, and then the right lung basically has a superior lobe. I'm just going to abbreviate that S lobe. You'll probably have your book in front of you when you're watching this. And then we've got a middle lobe, and then we've got an inferior lobe. Whereas the left lung basically just has a superior lobe and an inferior lobe. Okay. And then basically these lobes are separated by fissures. All right. So this right here would be the horizontal fissure. This would be the oblique fissure, and then this here would be the oblique fissure, essentially separating the lobes. And now the left lung, notice right here where you see the kind of on the lower side of this lung, you see this you see this indentation right here. This is basically where the left ventricle compresses up against that left lung, and that's what's called the cardiac notch. All right, that's what's called the cardiac notch. Okay. Now, what you're starting to notice here is that, remember before when I said the lungs are really soft and really delicate? Basically, like I said, this tissue is really soft. So basically, the lungs conform to whatever objects it's up against. The outer portion of the lungs are very convexly shaped. All right. So basically, as air fills in and they're pressed up against the curvatures of the thoracic cage, that's how they develop. So they develop against the curves there. In the medial portion, the lungs are a little more concave. Again, a lot of it has to do with the presence of the heart. And then at the base of the lungs, they're more concavely curved because the diaphragm domes up into them. And then plus there are some organs in the abdominal cavity sitting right under the diaphragm as well, putting a little bit of upward pressure against the lungs. So like I said, that really soft tissue kind of takes on the shape of the basically of the structures around it. All right, and then so that's kind of something to keep in mind. And then if we look at the medial surfaces of the lung, basically this area right here is what we would refer to as the hilum. Okay, now that's a word we're going to come back to because soon there's going to be some urinary system videos coming up. Or when you learn about the urinary system, you'll also learn about the hilum of the kidney, which is also on the medial side of the kidney, kind of the inwardly curved part there. And I like to think of a hilum as a high traffic area where there's a lot of materials going, where there's a lot of structures moving into or out of the organ. So, for example, in the hilum of the lung, you would have the pulmonary arteries going in, the pulmonary veins coming out. You'd have the main stem bronchi going into each lung. So basically, there's just a high traffic area here. Same thing with the kidneys. You've got the renal artery going in. All right, you've got the renal veins coming out. Then you've got the ureters carrying urine down to the bladder. All right, so there's some similarities between the kidneys and the lungs in terms of the hilum. So that's why it's important to understand that structure right there. All right. And then, like I said, we've already talked about the pleural membrane, all right? I already kind of went over that. But, and actually what I forgot to mention. So basically this dark coloration here, these are the lungs. And then, like I said, this right here on the rib cage, this would be the parietal pleura. All right, the parietal pleura. And then on the lungs themselves, you would see the visceral pleura. So like I said, if someone got stabbed right here, all right, and this pleural membrane got punctured, that would cause air to flow in because there's a greater volume of air outside of our body than in our thoracic cage. So then as a result, that would that would essentially drive air in, and then that air would build up around the lung and cause it to collapse. And when we build up air inside the thorax, that's what we refer to as pneumothorax, air in the chest. All right, air in the chest. All right, and what else did I want to say here about that? I can't think of really anything else that I want to say about that. Yeah, I don't know. I guess that's about all I really want to say about the pleural membranes. I thought there was something else I wanted to say. Yeah. Oh, I guess I was going to say as well. When we kind of those pleural membranes and that fluid that's in between them. Now remember that when we inhale and we breathe in, the dimensions of the thoracic cage are actually going to get larger. All right. We already talked about the friction reduction aspect of the pleural membranes, and then plus where there's any membrane surrounding an organ, it's going to compartmentalize the organ and make it hard for infections to spread and travel. But they also play a key role in creating a negative pressure environment during the inhalation process as well. So when we breathe in and basically the diaphragm expands the dimensions of the thoracic cage, and the intercostal muscles kind of rotate the ribs up and out, external intercostals to be specific. What's going to happen as that thorax increases in diameter or in size, remember that sticky watery fluid that's in between the two pleural membranes, that's also going to kind of allow that's going to kind of pull on the lungs and allow them to expand a little more easily. And then as the lungs stretch out, remember the lungs are very elastic. When we need to exhale, then those lungs are going to be able to recoil because of their elastic properties, which we'll talk about later on as well. So the pleural membrane is very important. So now we've finally gotten to the alveoli, the physiologic anatomy of the lungs, and the alveoli are basically the sites of gas exchange, or the respiratory zones. And there's about 300 million alveoli per lung. All right, so about 600 million total. Now, structurally, the alveoli are made up of, there's basically three different types of cells that are located within the alveoli. Basically, there are what are called type 1 cells, and those are just the simple squamous epithelial cells that basically form the kind of circular structure of the alveolus. And then there are cells that are called type 2 cells that make up a much smaller percentage of the cells. Make up maybe, I don't know, 20% of the cells that are in there. But however, they play a very critical role because alveoli are like any other. They're like any other organ. There's fluids associated with them, and where there's water, there's going to be, in this situation where there's water and air, there's going to be surface tension. So type 2 alveolar cells produce a phospholipid called surfactant, which we'll talk about later, that is designed to reduce the surface tension that water would exert on the alveoli and prevent them from collapsing. All right, and then there are also macrophages within the alveolar air sacs that are. I mean, you guys know what macrophages do. They eat things. They consume things. So I mean, even though air is coming in contact with a lot of mucus on the way in, there will still be a chance that material might work its way into the lungs, and it's nice having those macrophages there to clean up any debris. All right, they're often the macrophages are often called dust cells because of the particles that they remove. Now, one thing to bear in mind about alveoli is that they're incredibly thin. They're only about half a micron thick, and they're really close to pulmonary capillaries, right? The only thing that really separates them would be the basement membranes of the pulmonary capillaries, and the simple squamous epithelial cells of the alveoli. Okay, so as we take a look at this, now remember that alveoli are typically found, more often than not, are found in clusters, or they're found in sacs. All right, and there could be upwards of, maybe 20 to, close to 100 different air sacs on the, at the ends of these terminal bronchi. All right, so we've got these bronchioles. Now remember how I said that the smooth muscle, that basically we have these thick circular walls of smooth muscle that surround bronchioles. All right, and if we constrict and dilate this smooth muscle, that's going to limit the amount of, or reduce the amount of airflow coming in. All right, and vice versa. Basically, if we dilate them, that will increase airflow, and we'll talk about factors related to that in the next video. And then basically, so gas exchange starts to occur along the terminal bronchioles, because notice how along these terminal bronchioles there are some individual alveolar air sacs, and then as air comes, so basically air could enter one of these individual sacs, come in contact with pulmonary capillaries, a gas exchange. Now you'll also notice about these alveoli that within these clusters that there are these pores, these alveolar pores. Now these are important because basically as air comes in and enters, this allows air to flow throughout all of the alveolar air sacs and allows them to fill up, all right, and then undergo the process of gas exchange, all right. So that's kind of something to keep in mind about these alveoli as well. And then when we think about the pulmonary capillaries, then, like I said, the pulmonary capillaries are incredibly close to the alveolar air sacs. Like I said, they basically coat the air sacs. And that's why I kind of like this picture, because it just shows how they essentially coat them. And then you can see here, when you look at the arrows, basically as air flows into this cluster of sacs, it will distribute throughout those pores and then move into these each alveoli or alveolus, and then that air can undergo gas exchange. So even in these alveolar air sacs, we're still continuing to spread air out. We're increasing the surface area of the distribution of air. All right. And then, like I said, the close proximity of these two allows for rapid gas exchange. So we have very thin membranes, half a micron thick, and there's only about 1.5 microns in between the capillaries and alveoli. That allows for rapid diffusion of oxygen in and CO2 out. All right, and for example, someone has pulmonary edema. What happens is that as they build up fluid in the lungs and the tissues, what could happen is that could cause the pulmonary capillaries to move further away, and then as a result, that is that's gonna slow down this gas exchange process, and then that's where you're gonna see the respiratory complications associated with that, the rapid breathing and stuff to compensate. Okay. And something I'll mention right now, and another concept we'll revisit in a little bit, is the concept of ventilation and perfusion. All right. Remember, perfusion is how much blood that is essentially filling up an organ and then undergoing gas exchange, and then ventilation is, remember, airflow in and out. Ventilation and perfusion essentially have to match one another. All right. So basically, that's why when heart rate goes up, your breath rate proportionally goes up with it, vice versa. All right, so the two are going to equally rise and fall to meet our demands. And if there is an imbalance between this, then that's when we would say there's an increase in what's called physiologic dead space, which is something we'll visit in another video when we talk about lung volumes and ventilation rates. Okay. So that is essentially the structure of the lower respiratory system, and so now we'll start moving into some of the more physiologic topics. The next video is going to cover the mechanics of breathing, and basically talk about respiratory muscles and the structural properties of the lungs that aid in that process.